We move to the next session. So Dr. Chu will give us a talk about the experience sharing with the TEVAR innovations. We all aware that Dr. Chu is very experienced. And I think he did thousands of aortic complicated cases. He will share us the innovation of the TEVAR treatment for the aortic patients. Dr. Chu, please.
Thank you, Chen Pang. Thank you for the introduction. So it's my great pleasure to be here to share our experience and discuss the new device focused on aortic arch for all of you. I'd like to also thank a lot for Professor Bong's invitation. So as we know nowadays, since the different anatomy and the different pathology of the aortic arch, so we do believe that to treat the aortic arch diseases, we should have different methods, including the handle procedure. What's the meaning of handle? Handle means the first letter is hybrid, the second one is open, the third one is endo. So that's the data from my department just in 2021. So when we find it, different kind of technology are applied in the aortic arch. So that's a new device nowadays used in China. For example, the chimney, so we have the longit. The inside fenestration, we have the skirt. On table fenestration, we have the self-image fenestration technically. The single branch, we have Castor, and we have Mona Lisa, and the Nexus. The branch sling graft, we have a Cook or Relay. The three branch, now in clinical practice, we have the different kind of device from the European countries and also the concave supina. So that's a different kind of methods. The first one is chimney. We emphasize it's still very important to treat some special patients by chimney. You can suppose in such kind of anatomy, no matter branch sling graft or fenestration technique are not so fit, only chimney. So especially to the emergency and very huge severe aneurysm, the chimney is very convenient. Also to the aged patient, we perform chimney very quickly and get a very good result. So that's a case we have done within 19 minutes. Then the patient, the branch vessel keep pattern till now. Almost 3 years. But we emphasize the endolic of the chimney is terrible complications. So, of course, the mild endolic we can wait, but we have to invent the new device. So this one is a longit. We designed this special device for several years. And nowadays, we finish the few cases and also we have the multi-center investigation in China. So 115 cases are involved. Then we find the result is very nice. Finally, when we find it no stroke and no paraplegia, also the mortality is only 0.67%. Also, we may find it no secondary intervention is very high, especially the endolic. The final result is only 4.2%. So that's 1 year's follow-up. So that's a case we have done by longit. So you may find it. This device is very convenient for you to do it. No matter the instant result or the long-term result, no matter the dissection case or the aneurysm case, it seems like this device works well to the patients. Especially, we'd like to say, this device, the inner sling graft is hard enough to accept the chimney technique, but the skirt is very soft to occupy the space between the sling graft to prevent endolic. So another one we emphasize is the fenestration, including the on-table fenestration. So we have now reported this morning. So in fact, just now I I just listened to the doctor from Yuan. He introduced using Medtronic. It's also the self-image fan switching. So, use this technique, you are so familiar with it. No matter one branch vessel fan switching or two branch vessel fan switching, we emphasize the aortic arch should be very flexible. No angulation. So just now, the doctor from Yuan emphasized, you put the tip forward, then he cannot put a mark on the above. Why? Because angulation. Especially you want to perform 3 branch vessel angulation, you put forward, it will migrate. So you can suppose, since it's the angulation of the aortic arch, the tip cannot go forward just according to your ideal place. So that's very important. So especially we emphasize, if we use on-table fan switching, we can treat it very quickly, or even we can preserve the vertebral artery separate from the aortic arch. So that's fan switching. We just use one exercise from the femoral artery. You can step by step put a wire inside to the left carotid, then to the left subclavian, then deploy the covered stent, then get a very good result. No matter 1 branch or 3 branch, so we can do it very freely. So this case is the beginning in 2007. I treat the patient by the relay system, so it spends lots of time. So that's a live puncture CD aneurysm we use on table fan switching, or the whole procedure within 1.5 hours. The patient recover back on the 2nd day and discharged the 1st day. So it's very convenient for you to do it. So this technique is well accepted by doctors not only in China, but also in different countries. So we finish the first fan switching in different countries, and also we get very good result. Even in the London, in England, they love these procedures. So we emphasize to our severe situation of the angulation of the aortic arch, we prefer the in situ fan switching. So this device, we have already finished the multi-medical center investigation. It seems like the mortality is very low and the stroke is very low. And we also find the endo-leak at the beginning is 5.9, but finally, during 6 months later, it's only 2.5. Because the CSGIRT, the multi-center investigation, is not only focused on aortic dissection, we also use this device to treat aneurysm. So we emphasize the aneurysm. If you want to make fan switching, it's very hard for you to prevent endo-leak. So that's why we designed the CSGIRT to prevent endo-leak. So in such fan switching, we have 2 devices. One, this morning, another doctor showed you the bolon puncture needle combined with a Fustar. Another device is a device we had ever invented. It's a bending branch vessel puncture system. So we invented in 2018. This is a case we have done with a bending puncture system. So you may find it's very convenient for you because the tip is just focused on the branch vessel. Then you can put the puncture needle to go inside to finish the whole procedure. We just use a small balloon and change to the big balloon sequence by sequence. Then you can finish all the procedure very quickly and get a very good result. No matter dissect it to the LSA or any other place, this device is also very convenient for you to do it. Especially, it seems like the follow-up is also very nice. Another one we'd like to introduce is a caster. So this one it can be available in China, also in some countries. We find this device, the result is perfect. So we can do it in different kind of situation, including the aneurysm, including the dissection, including the PAU, including the severe aneurysm. So this one is a severe PAU. We can use combined with a fan switching technique to treat. Because this morning I just emphasized the catheter, the device is easy to drop into the small curve. So in such kind of situation, the best treatment is just to give a cuff fan switching. It's very convenient for you to do it because you can make a large fan switching to focus to the bronch vessel. You just want to cover the small curve. So you can do it very quickly, just within maybe 15 minutes to finish all the procedure, then deploy the bronch stent graft, go inside to the fan switching area. Then you can get a very good result. So that's a patient's follow-up. You may find this very good. So lastly, we'd like to introduce the 3 branch vessel reconstruction by the concave Supernal. So this device we designed and animal study for more than 10 years. Then you may find it, the bell stent covered. Bell stent combined with a covered stent, 2 internal branch to the forward and 1 internal branch inside to descending. So it has different kind of the types of the standing graft. So this one is anodine with severe tortuous sitting of the bronch vessels, also lots of thrombosis and plaque. So it's easy to suffer from stroke if we treat by no matter by open surgery or by totally endo procedure. So we perform angiogram first. In fact, it's anodine, the diameter is 6.5 centimeters long. So we deploy in the main body. Slowly, you may find it because this concave Supernal will run across the aortic arch, so it's very stable. The ascending aorta has 2 tunnels, descending aorta has 1 tunnel. After deploying the main body, we perform the angiogram because this time still the bronch system is not involved. So you may find the anodine still appear, but we emphasize no ischemia. That's very important because you deploy the main body, and you needn't worry too much about the ischemia or the cranial. So you can wait. You cannot finish the operation today. You may wait for 1 week, even 1 month. You still cannot cannulate. You may invite another doctor to come here to help you to finish the cannulate. But we emphasize the cannulate is very easy. So we do it and get very good result. You may find it. That's a follow-up. No endo leak and the bronch vessel keep patterned. Then we finish the second case. You may find it. It's an anodine. So this case, we do it very quickly, only 55 minutes. We step by step. We perform angiogram, then we deploy in the main body, we insert the valve, and we deploy the bronch stent graft, then from the uromate to left carotid, then lastly to the subclavian artery. After all this finished, we use a balloon to balloon it. The whole procedure finished. The last angiography from the first angiography is only 55 minutes. So that's a follow-up. You may find it. It's very good. So this one is also a 77 years old severe PAU. So we do with a concave Supernal. We deploy the main body. Of course, the PAU exists, but you may find it. No ischemia. That's very important. If no ischemia, the doctor can slowly or can impatience to cannulate in the bronch vessels, then step by step to finish all the procedure. So lastly, you may find it the instant result is perfect. Also, the follow-up is very nice. The bronch vessel keep patterned, no endo leak, no thrombosis inside. Another one is that is 79 years old patient, the type 3 aortic arch, not so plaque, not so thrombosis. So this case, we do it not so easy because the LSA is not easy to cannulate to the distal side. So we have to use a snell to pull the wire out, then we can finish all the procedure. So this case, we spent more time to finish the whole procedure. But anyway, it's still a very good result. You may find it. You may find the PAU is so severe, even graft almost drop into the PAU area. So that's a follow-up, but no complications. So we emphasize the canonic dissection is very challenging. So in this case, the large area is very near the innomate. Then we perform concave supernal for the patient. We use the bronchoscopic graft inside. Then we use a balloon to balloon it. We have to use a kissing balloon to open the true lumen. Then we can totally seal the every bronchoscopic graft. But anyway, since it's canonic, just the instant results still mild endo leak. But the follow-up 1 month later, no endo leak. Very good result. And that's another case. It's not canonic, but we can do it very freely near the innomate rupture area. So we do it very quickly to finish the whole procedure. Also use a kissing balloon. Then you can get a very good instant result, no endo leak. So that's a follow-up. So this case is a very challenging case, 79 years old. Also the type 3 aortic arch. So we spent 103 minutes to finish the whole procedure by kissing balloon to preserve and seal the bronchoscopic graft. So that's a follow-up. You may find it very nice. Then this case is also an aneurysm. So we do it very quickly. Only 37 minutes to finish the whole procedure and get a very good result. So this case, another one, we spent 39 minutes. So this aortic arch is very nice for you to do it, to get a very good result. Then this one is a gentleman, a huge aneurysm, but anyway, we finished the whole procedure only 15.3 minutes. We use a kissing balloon to finish the whole procedure and get the very good result. So summary, we'd like to emphasize to focus on the aortic arch, we have different kind of method. The endo, I suppose, that's a future. So nowadays we can still use a chimney, filtration, and a bronchoscopic graft. So the combination by open surgery or hybrid and endo is a must. No matter nowadays, I suppose in the future, maybe 10 years, even more, is very important. Thank you so much. Thank you.
Yes, sir. Really impressive technologies and yeah. Any comments, any questions from the floor? Napon.
For me, I have only one question. Just when all of these products will be available in Thailand?
Thank you very much. So I suppose the C-skirt and the longet will be given to the market soon. But the concave supernal, we still need maybe at least 1 year. So not in Thailand, but in China still. So because it's very strict by the CFDA. So we have to get a very good result. You know, somebody used the European device to treat the aortic arch. The high mortality and the high complications, especially stroke. So it's not permitted. You know, in Full Eye Hospital, we doctors, the cardiovascular surgeons are very experienced. So they can do the total, the bento, the whole aortic arch replacement very successfully. So if we do endo, too many complications is impossible. So thank you so much.
So this device in China still experimental or is just
still just waiting for the
approved?
Yeah, approved by the CFDA. Because the CFDA, so after you finish the clinical study, it needs at least 1 year. Thank you very much. Thank you.
Any questions from the floor?
Yes, please.
Thank you very much for your excellent present. I'd like to ask you, do you have any experience of using your stent in the shaggy aorta? That is shaggy
aorta?
Yeah.
Is it like dirty, shaggy?
So the first case we have done is combined nasal thrombosis. So the diameter you calculate the inner face is only 5.1 centimeter, but in fact, the diameter is 6.5 centimeter. Lots of thrombosis inside. So, thrombosis inside the aortic arch is very challenging for you to do, no matter open or endo procedure. So that's why we emphasize if we use a standing graft to very stable to occupy the whole space of aortic arch, then the thrombosis is not so easy to go inside to the brain. Why? The first image I show you, you may find it because the concave supina, so you may find it. The first case is very, very stable because deploy the main body, the thrombosis are just isolated from the graft. So in such kind of situation, that's why our cases has nice complications. You may find it. I show you this one. The first case I show you. Yes. This one is aneurysm, contain lots of thrombosis inside. In fact, other patient also has thrombosis. So after deploying the main body, you may find it. This time, the graft already occupies the whole aortic arch. For example, if the thrombosis inside here, there's no problems. Let's isolate. Also, only here, the bloodstream comes from the ascending aorta to branch vessels. So it's safe enough to prevent the stroke. Very good question. Thank you.
Okay, thank you, Prof. Shu, for a very excellent talk and very inspiring. I just wonder, my questions, in your center with a high volume, how do you decide whether this is going to be endovascular or this is going to be open surgery? Because with all this modality available and very good outcome in your open surgery, so how the decision for the which treatment to be tele with, so especially in your expert hand, so how you decide?
That's a good question. So, in my department, we cardiovascular surgeons and vascular surgeons are combined together. So if the patient come to our department, we will discuss together, which is the best way for the patient. So we will give the evidence. So otherwise, maybe in some medical centers, the cardiovascular surgeon would like to say, I can do it by open surgery. But the endovascular surgeon say, I can do by endo. But you have to give your reason in my department. The patient's benefit is the first option. Thank you.
Okay, can I just continue with Dr. Aziz's question,
Yeah.
Professor Chu? So which case you will do chimney? Which case you will do fenestrated on table in situ? Which one you think about the branch and that you have so many options. Which one for which?
Okay, good. Thank you. So our Professor Bong has a very good question. So, in what kind of situation we should perform chimney? Well, we'd like to say to the emergency case, especially the patients lots of complications or very aged people. So even sometimes the patient cannot be given general anesthesia. So we can do chimney very freely and very quickly to perform.
Sorry, and then percutaneous puncture of the carotid.
Yes.
Okay.
Yes, very quickly. But we emphasize only with the no stenosis, no severe stenosis carotid. It's very important because the branch here is very easy, right? But the carotid, left carotid, you have very much attention. If the fenestration, we emphasize on table fenestration, we have to treat the patient first, the anatomy of the aortic arch, no angulation. Very important. Angulation, you make on table fenestration, not easy. That's very important. You want to treat on table fenestration, also another mask is a pathology area, the disease area to the fenestration branch vessel at least 1.5 centimeters long. If it is a newcomer, a beginner to do this one, I suppose maybe 2 centimeters. It's much better. So At the beginning, we are very, very carefully to select the patient, especially in 2007, the first case I have done, I just focus on the small curve pathology. The big curve pathology, you have to pay much attention. The unstable fluctuation is easy to suffer from endoleak. So, in what kind of situation we select in situ fluctuation? So, if the aortic arch exists angulation, also the patient, the condition is not so good for him to be given open surgery. So we suppose during this time, no matter emergency or the normal cases, we can do in situ fluctuation. At the beginning, we have no bonding branch vessel puncture system. Then the severe angulation of the LSA, we cannot do it. But nowadays, I just show you the device. It's very flexible, then you can use this device now. Otherwise, it's easy to turn to be failure. So, the in situ fluctuation. Also, in situ fluctuation, we emphasize the any reason you still have to pay much attention, not compared to dissection. Dissection is a plaque. Then the intimal plaque, you can turn back to the normal aorta, but any reason you make fluctuation in situ, it's easy to suffer from endoleak. Okay, thank you so much.
Thank you.
And just maybe last question, sir. If in urgent case, Dr. Chu, and you need to do more than one chimney, do you prefer to do 2 or 3 chimney or 1 chimney plus the hybrid?
Yes, very good question. So, in fact, about 10 years ago, many cases will perform chimney for the patient because it's a simple method, but the big way for you to go. But some cases still will suffer from endoleak, so it's not so good. So that's why nowadays more and more patients will be done by fluctuation or the branch sling graft. Also, you're right. The bypass from the left colony to left subclavian is still a must. Among 1 year, you may see my data. Within 115 cases 1 year of aortic arch, still there are 2 or 3 cases will be done bypass in the very special situation of the anatomy. So that's very important. With surgeons, we have to do it. Thank you for a good question. Yeah.